Hello friends, in this video I'll be speaking about low IOP Phaco and is it possible using Alcon Legion system. So I'm going to do a case of PPC type 2 as you can see on OCT, and here I'll be using the sideways sculpting method which I have described. So I start with the one main incision which is 2.8 and two side incisions which are 180-degree apart. After staining the capsule, I am going to do Capsulorhexis, which is oval in shape. So generally, that is what I use when there is a dense cataract with posterior polar nature. Then it's better to have a oval Capsulorhexis. It helps in two ways. One, the usual problem area is the subincial epinucleus which remains stuck. So when you have oval Capsulorhexis, you can remove it easily. And second, in case there is a PC tear and we want to remove the nucleus, it's easier to take out from the oval rhexis, and same time we can do optic capture of the IOL. This is the most important step here where I am doing mechanical dissection. So instead of hydro, we have to do mechanical dissection using a nice iris repositor, and we have to do it 360-degree. Do not leave any area devoid of this mechanical dissection. So that frees that cortex and epinucleus from the bag, which makes the surgery quite easier in the later part. Now, when we start doing the trenching, I'm going to use this technique which I have described, and it's already there. So what I'm going to do is I'm going to use torsional phaco here, a linear power of torsional phaco in order to a regular trench first. I want to go as deep as possible, almost up to 90% of the depth. And once I achieve that, what I'm going to do is move the phaco tip sideways. So in posterior polar cataract, you cannot rotate the nucleus, because if you rotate and the posterior plaque is attached to the capsule and capsule is weak, then it might just open up the PC and there is a chance of nucleus drop there. So this is what I'm going to do using the Ozil Phaco. I'm giving sideways sculpting. So again, this side sculpt is also made to the same depth as the main trench here. So idea is to have four similar technique like four quadrant, but without rotation of the nucleus. And there is an advantage of having Ozil here, because doing this technique with longitudinal is a bit difficult, though we can do it, but it's easier with Ozil because of its sideways movement of the tip rather than longitudinal movement. And once it is done, what I'm doing here is I'm carefully separating these quadrants from each other. So you can see that all throughout I didn't rotate the nucleus, and still I could achieve four quadrants there. And now I shift to quadrant removal. Now quadrant removal, you can see that I'm using again torsional phaco with 5 pulses per second, and I'm using low bottle height throughout, just 50 centimeter block bottle height. And what I have done is I have reduced the flow rate to 30 instead of 40 which I use normally, and vacuum starting from 220 to 400 instead of using a panel mode or high vacuum like 450 or 500. I'm using it in a linear manner, and that to on lower side. So even with this machine we can do low IOP phaco. Like in this case, we just have to titrate the parameters accordingly. So the first quadrant is out. Always watch the anterior chamber. Whenever you find a lot of fluctuation, try to titrate, try to reduce the flow rate and vacuum, and make sure that anterior chamber remains stable. The advantage of low IOP phaco in case of posterior polar cataract is that, for example, this patient is around 40-45-year-old, and in this patient, normally what you see is that whenever you enter the phaco probe in the anterior chamber, and if you have kept high bottle height, that what we usually do is 90-100 centimeter, you'll always find that AC deepens suddenly, and that might rupture the posterior capsule. So here you can see that AC never deepens, and you will see it whenever I bring out my phaco probe and enter it again. So that's the advantage of having low IOP settings here. And now what you can see is that I'm nudging the pieces out of the bag instead of again any rotation there. I could take them out, bring it to the center and remove it by using this low IOP settings. Now, this shows that even with gravity assisted fluidics, we can manage to have low IOP. Of course, we cannot go to the lower extent like 20, but we can manage at around 50 centimeter of bottle height, which is good enough for our cases. Now you can see that posterior plaque is there remaining. So I'm going to do the OVD BSS exchange here, remove my Phaco probe, and I'm going to start IA. Now watch, when I enter with IA probe, because of this low IOP setting, you find that there is no deepening of the anterior chamber, which you will find if you keep high bottle height. So that's the difference here. Remove all the cortical material, remove that remaining epinucleus, and here the oval capsulorhexis helps because it's easier to access that subincisional cortex and subincisional epinucleus, and you don't struggle with that, and you don't need to do visco dissection and other techniques here. Avoid polishing, avoid polishing the posterior capsule in these cases, even if you feel like that, because there might be a little defect there which might open up. Again, OVD-BSS exchange to end, that's IOL in place, and end of the surgery. Thank you so much.